The purpose of this video is to provide you with the important information about the best surgical treatment for your condition. In order to do a cervical disc replacement, it's an anterior approach, meaning that an incision is made on the front of the neck, usually to the left of center, sort of in this area depending on the level. And then the surgery is to go down to the front of the spine and remove the disc at the appropriate level and remove the bone or disc herniation that's causing the spinal cord or nerve compression. And once the disc has been completely removed, then an artificial disc or disc implant is placed into that disc space. The reason to consider cervical disc replacement is generally to treat pain. Oftentimes patients will have pain in their neck or shoulder, or often extending down into the arm or hand. They may also have associated weakness or numbness, which also potentially can be improved with this type of surgery. One of the primary advantages of the cervical disc replacement procedure is the motion preservation aspect of the operation. And that's important because it reduces the risk of degeneration adjacent to the surgical level, which is one of the most common issues with cervical fusion, and is really the key advantage. This does carry some risk. There's two types of risk really. One is the risk of anesthesia, which has to do with your medical comorbidities, things like high blood pressure or diabetes, age, other medical conditions, and it may be that you would need to have an anesthesia clearance in order to have surgery. The second type of risk has to do with the surgery itself. As I mentioned earlier, an incision is made on the front of the neck and the dissection is carried down to the front of the spine. There are important structures in the neck. These would include the esophagus, which connects the mouth to the stomach. It lays right along the front of the spine. The trachea or windpipe lays right in front of that, and both of these structures have to be moved or manipulated in order to gain access to the front of the spine. The carotid arteries, which carry blood to the brain, are in the operative field, as is the spinal cord and nerve roots, and so any of those structures potentially could be harmed. While that is a little scary for patients, it's important to realize that this is a very common type surgery. Most patients do very well. Complication rates are very low. Patients as a group do very well with regard to getting relief, and oftentimes these surgeries can be done on an outpatient basis even. Immediately following the surgery, you will return to the outpatient surgery area, and most of the time patients can see improvement immediately in their arm or hand symptoms. Right after surgery, people will typically have a little difficulty swallowing, may have a sore throat, and often will have some pain in the neck and shoulder. But usually the patient is able to get up and walk and mobilize and eat or drink, and once they've been able to do those things and empty their bladder, then they're able to go home. Again, typically the same day as the surgery. There is a small drain that I usually remove prior to the patient being discharged. The main purpose of surgery is this type of surgery is to relieve pain, most commonly in the arm or hand, but also in the neck and shoulder. And most patients do get excellent relief of these symptoms. People will be in a collar for a short time, just a soft collar, and typically will follow up with me usually about a week to 10 days after surgery. Long term, the expectation would be that the shoulder and arm pain would be significantly improved, if not completely relieved, and that patients would be able to return to full activity. There will be a short course of some outpatient therapy for most patients to help them return to normal function. And again, normally there's no long-term restrictions or limitations with regard to your usual activities.